Chapter 14 Vision and Perception. Image perception. Misperceptions can be dangerous in radiography. Eliminate preconceived ideas about an image to overcome misperceptions. Image perception. Perceptual difficulties faced by radiologists. Radiographers must become aware, and the radiographers can produce patterns that help the radiologist make a diagnosis. Human eye. We still don't know all aspects of vision, but we do know the anatomic design mechanics. So first it catches the light, it's going to transform it to the nervous signal, and then it transmits it to the brain for processing. Hint, it's probably an important factor to look at this diagram and kind of memorize where and how the anatomy. Visual anatomy. Aqueous humor, carina, iris, and lens all gather and focus the light. Retina cells transform light to the nervous signals, and they do this through rods and cones. Optic nerves transmit nervous signal to the brain. So again, important factors here to know what each of them do. Visual correction. Coronal malformations due to incoming light not properly focusing on retina. Myopia, hyperopia, and presbyopia are all some common disorders. You will end up with a loss of detail, and these three are the most common. It's easily perceived and corrected, and we do that through contact lenses. Visual physiology. Conversion and processing problems, unsure if cause originates from light-sensitive cells or trouble with neurologic processing or your mental perceptions. As techs, you need to know these conditions exist and how they can alter your perception. Time the human eye converts and processes information is 0.2 seconds. If information to limited vision resets for another 0.2 seconds. Only improvements in quantity and quality of light photons can improve image, and we also can look at film emulsion. Rod and cone cells emit neurologic impulses when simulated by light. More rods than we have cones. Cones primarily located within the fovea centralis, and rods cover the rest of the retina. So you have approximately 7 million cones and approximately 100 million rods. So they're very different systems, and we'll talk about that more as we progress forward. Photopic or cone vision. So obviously this is going to be controlled by cones. It is considered to be daylight vision, so it needs to have bright light. It is our color vision. We need light in order to see color. And there's a need 100% light photons to emit neurological impulse. Cones contain one of 3 light-sensitive pigments, each sensitive to a different range of visible light photon wavelengths or color, most sensitive to yellow light. So color blindness occurs due to the lack of cones sensitive to a color or colors. Visual acuity. High concentration of cones at fovea centralis results in sharp daylight vision. Poor peripheral vision is due to the lack of cones in the rest of the retina. Cones detect changes in brightness, improves contrast perception, and so thus differences in density as well. This is just an example and showing you a scale, and it's in your book on 14-3, and it's just showing you, your visual human ability of light. Scotopic or rod vision. So again, this is going to be mostly generated by rods or controlled by rods, aka it's also known as night vision, so sensitive to low light levels, and it can generate neurological impulse when struck by as few as 15 light photons. So aka again, this is night vision, where cone or photopic is daylight vision. Scotopic rod vision cannot function in bright light. Rhodiaspin is bleached out by high light levels, and we also use for dark adaptation. The example of that would be like a dark room. Rhodiospin is bright light, causes short blindness, kind of like staring at the sun. It's also called vision purple, and it's most sensitive to blue-green. It cannot distinguish wavelength, but are most sensitive to green light. It cannot perceive colors in low light. Visual acuity, rods not as concentrated as cones and distributed over the peripheral retina. Dim objects are best viewed peripherally. Inefficiencies of process, large discrepancies between the number of X-ray photons and the number of light photons. More X-ray photons are used in creating the image, compared to the number of light photons striking the retina to view the image. Threshold detection, visual phenomena associated with viewing extremely small objects. It's dependent on resolving power of total imaging system. Must minimize noise to decrease detection. So again, this is just helping us visualize small or fine details. Boundary effect is due to the difficulty seeing contrast differences that are far apart. If an objects are close together, only a 2% difference is needed. If objects are far apart, a difference of 20% is needed. So rule of thumb, with density, 25 to 30% change is needed to be visualized. Radiologists can see density better at long distances. You need to have high contrast. Mach effect, neurologic basis for boundary effect. Some situations prevent neurological impulses from being transmitted by the retina, namely bright light. This is showing you an example of the Mach effect. Mach effect, change in radiographic densities changes neurological impulses from the retina. This is an example from your book as well. A is just showing you the density differences, B, a compare actual to optical, and C is the optical nerve response from A. This is also an illusion that is known as edge enhancement. It compresses density scale, makes boundary more distinct. Look at the left side of step wedges. Notice that each step appears lighter the closer you get to the next or darker step. And so you end up with a loss of detail. This is just showing you again another example of edge enhancement. Eye motion. Moving the eyes while viewing an image improves contrast perception. Photosensitive cells of retina reach to a saturation point quickly. Moving eyes minimizes optical saturation. Veil glare. When intense light from the view box hits the eye directly, bright light scatters inside your eye, similar to the Compton effect, and it decreases contrast perception. Viewing distance. Results change when viewing distance varies. Also the threshold effect. Light also changes with angles, and the intensity varies, like with the inverse square law. Blind spot, which is created from your fovea centralis, is at 9 inches viewing distance. Rad techs overcome this by varying viewing distance. Pattern recognition. Perception of combinations that can be classified together to make a diagnosis. RADs need information presented in a consistent manner. Example, difficulty like an upside down image. And so again, our radiologist uses or views as if they're facing the patient. Comparing mental images of patterns. Anatomical, physiological, pathological, and histological. This might be helpful information for a future exam. Not much known on how it works. True domain of the radiologist. Controlling image in space. Radiographer's challenge. Position the area of interest so that image quality will be improved. Start by mentally visualizing the object of interest floating within the body. Art and skill to manipulate object to correct position. How is the object oriented to the beam and the image receptor? Thinking in 3D. Effective positioning skills. Dependent on knowledge of location of structures, shape of structures, relationship of structures to one another, certain structures must be manipulated to demonstrate the area of interest. 3D versus 2D. A single radiograph can only display two of the three dimensions, so it's really missing depth. So again, what two dimensions do you have? You have length and width, but you are missing depth. You must have always two images at 90 degrees opposing views to perceive depth in radiography. Dimensional views are AP, medial to lateral, or superior to inferior. You must visualize anatomy of structures. Radiography is art. Have fun and get creative. Look at difficult patients as a challenge to manipulating your artistic talents. That requires a lot of skill. Example of traction view. Radiography out of the box. Bill Conklin is known for x-raying shells. Others might be flowers, fruit, other plants, fish, non-destructive testing, biological research, and veterinary medicine. Grin's rays. This is special tubes that will minimize the inherent filtration. Low energy from 1 to 30 kVp. It's used in forensic, which is like ink on money, fingerprints, contents, art restoration, and archaeology. So mummy remains, jewelry, disease, diet habits. And then also could be poetry. Chapter 15, beam restriction. Controlling scatter. Primary source of radiographic scatter in diagnostic imaging is due to Compton interaction. It's not part of the useful beam. Exposures on the image that are unrelated to the patient anatomy. This is an image of scatter. Controlling scatter, minimizing the scatter reaching the image receptor. We can do this by restricting the X-ray beam and also by the use of a grid. Restricting the beam, that also includes light collimation. It improves the image quality and reduces the patient dose by keeping tissue irradiation to a minimum. Restricting the X-ray beam. Primary factors that affect scatter production. 1. Kilovoltage. 2. The irradiated material. Kilovoltage. Penetrability of the beam. So quality. Higher kVp, higher percentage of transmission. X-ray interactions. Photoelectric. Higher percentage with lower kVp. Compton. Higher percentage with higher kVp. So increase kVp, increase Compton, decrease photoelectric absorption, decrease patient dose. So increase Compton, increase scattering of the actual photons. Kilovoltage. You do have a table in your book, 12-2, that show greater photons. The higher the kVp, the more photons exit the patient. At 50 kVp with 10 centimeter tissue, for every 1,000 photons, 990 or 99% will be attenuated and 10 will exit. 50% photoelectric, 50% Compton. At 130 kVp with 10 centimeter thickness, for every 1,000 photons, 940 or 95% will be attenuated and 60 will exit. So 25% photoelectric and 75% Compton, which decreases patient dose. Kilovoltage. Selection of kVp will be determined by the size of the part being examined and the desired contrast of the image. Increase kVp alone, you increase scatter. Increase kVp with decrease in mass, so the density maintenance formula, you decrease scatter. Reduce scatter, improve film quality. Irradiated material. Scattered production during interactions, or amount of scatter. Material volume and atomic number of the material. The material volume. Volume is increased by increased field size and increased patient thickness. So as volume increases, scatter increases. Atomic number of the material. A higher atomic number, more electrons for the interactions, more photoelectric interactions, less scatter. Reduce scatter, improve film quality. When the beam is restricted, less scatter radiation will reach the image receptor, and as a result, technical factors may need to be increased to compensate for the reduction in the overall image receptor exposure. So as beam restricts, density decreases. Beam restrictors. There are 3 types: aperture diaphragms, cones and cylinders, and collimators. All of these help with scatter and reduce patient dose. Aperture diaphragms. These are a very simple device used to shape and limit the size of the X-ray field. It consists of a sheet of highly absorbing material such as lead placed at a certain distance from the X-ray focus. The X-ray field is shaped by a hole in the center and attached to the X-ray tube port. Aperture diaphragms, size, desired exposure field, SID, distance from the aperture to the focal spot, shape, rectangular, square, and round. Advantages: simple design, low cost, easy to use. Disadvantages: no light field available, different sizes needed to accommodate different receptor sizes or distances, and penumbra, which is off-focus radiation. Penumbra: geometric unsharpness around the periphery of the image, results of the diaphragm's close proximity to the tube port. Primary photons diverge from the tube port at varying angles and intersect with the structure of interest at varying angles when creating the image. So increase off-focus shadows of the image and is not scatter. This is showing you an example of penumbra. So reducing penumbra improves sharpness of the edges. Determining diaphragm field size. Because there is no light available, the technologist has to choose the size of the projected image on the film. This is done to avoid radiating areas larger than necessary and to avoid film size misuse. Projected image size equals SID times diaphragm diameter divided by the distance from the focal spot to the diaphragm. Here's an example of what a problem would look like. A diaphragm is placed 5 inches from the focal spot. The diameter of the opening in the aperture is a 2-inch circle. What is the projected image size at 40-inch SID? So 40 times 2 over 5 equals 80 over 5 equals 16. Cones and cylinders. Circular aperture diaphragms with metal extensions. These could be used for skull, spine, gallbladder, spots, or breast, and orbits. A cone is flared on the ends and cylinders do not flare out. This is just showing you an example of what these look like. Cones and cylinders. Advantages: relatively inexpensive, easy to use. Cylinders reduce penumbra and off-focus radiation. Disadvantages: physical weight, difficulty handling, tube angling when horizontal. Cones have fixed field size unless equipped with extensive sleeve. Cones do not reduce penumbra. This is showing you an example of what the different types of cones and what is projected at the image. This is an example of off-focus radiation. It is not scatter. Determining the cone field size. Projected field size equals SID times the lower diameter of the cone, distance from the focal spot to the bottom of the cone. Here's an example of this problem. The diameter of the lower rim of a cone is 3 inches. The bottom of the cone is 16 inches from the focal spot. What will the projected image size be at a 40-inch SID? So again, 40 times the 3 divided by the 16, you end up with a 7.5-inch circle. Collimator. Collimator sets of lead shutters at right angles to one another which move in opposing pairs. Most common beam restricting device. They regulate field size, they reduce penumbra, and they reduce off-focus radiation, which are all important factors. To reduce penumbra, it is done by the bottom shutters, and to reduce off-focus radiation is done by the upper shutters. This is just showing you an example of what it looks like within that collimator itself. Advantages: infinite number of field sizes, provides a light source, provides some filtration through the mirror. Disadvantages: more expensive and more complex. Positive beam limitation, or PBL, automated collimators. So 1974 to 1993, the law required PBL devices for all fixed radiographic equipment. These are sensing devices that determine the size and placement of the cassette and activate an electronic motor which drives the collimator LED shutters into proper position. Collimation. Responsibility of the radiographer. You should never exceed the size of the image receptor. Ancillary devices, such as lead blockers, lead impregnated rubber that can be cut to any size or shape, frequently used in lateral spine imaging to absorb scatter, improving radiographic contrast. Lead masks. These are cut to a particular field, size, and then secured to the end of the collimator, most commonly used in cerebral angiogram. And that is in, an example of this would be on 15-6.